Welcome to the second patient-centered seminar by the International Anal Neoplasia Society. For those of you who don't know who we are, we're the world's first professional society devoted to the prevention and treatment of anal cancer. And the disclaimer is the usual: this is not meant to be medical advice or to be a substitute for that. This is informational. Please keep your video off, stay muted, and if you want to ask a question, put it in the chat. We're going to be having Dr. Hips and Dr. McCluskey are going to be fielding some of the questions in the chat box, because sometimes there's many questions and comments. I want to personally thank the Anal Cancer Foundation, the HPV Alliance, and the Farrah Fawcett Foundation for supporting us in this. And I want to thank the Outreach Committee, who worked hard behind the scenes to figure out that we needed this kind of a seminar, and we have many to come. So I hope this one is useful for everyone. Our speakers are Dr. Jessica Corman, Lauren Oliver, and our patient and very knowledgeable woman, Marshall Carter Tripp. Lauren is from the UK, and she is in the United States right now, but was having trouble with her internet. So she has recorded hers, and if she manages to get connected, she will come in. At the end, we'll have some question time, which I think is the most important part, question and discussion. So with that said, we can move on to our talk.
Hi, thank you to IANS for providing me with the opportunity to talk to you all today. As I'm a radiation therapist by background, my talk will focus on how radiotherapy treatment can lead to side effects, including diarrhea, and how we can manage this in the acute setting. We'll then move on to look at chronic effects of treatment, and I felt that this quote from the Macmillan Cancer Support Report in 2013 sums this up quite nicely, that yes, patients may be cured of their cancer, but at what cost? So I just wanted to start by briefly looking at how radiotherapy actually causes side effects, including diarrhea, in the acute setting. So this is quite a busy figure, but I just wanted to focus on a couple of main points. So when we deliver radiotherapy treatment, for example, to an anal cancer, we know that this radiotherapy is going to cause damage, and that's what we want to happen. Of course, we want to damage those cancer cells so that they can't repair, and we can hopefully achieve a cure for the patient. But inevitably, we're also going to give some damage to our healthy tissues in the surrounding area. And when we cause this damage, we trigger the immune response. So as you can see here, there's a number of different effects that can happen. And ultimately, all of these lead to inflammation. And this is what gives rise to our acute gastrointestinal symptoms. Over time, we can then have an amplification of a reaction, and this can lead to intestinal fibrosis and our late gastrointestinal symptoms occurring. So I've just included this slide here just to highlight the close proximity of our healthy structures within the pelvis to the areas that we want to treat when we give radiotherapy in that region. So for example, if we were going to treat an anal cancer, you can see here we've got the anus and the rectum. I just wanted to outline the close proximity of the bladder and the small bowel, which in radiotherapy we class as our organs at risk within the pelvis, as well as some of the bones in the pelvis as well. And these structures are obviously healthy structures that are radiosensitive. And by this, we just mean that we know that a certain dose is going to lead to damage to those structures that's going to cause side effects and going to cause some symptoms, such as diarrhea. So when we plan the treatment, we have constraints for these organs at risk, such as the bladder and the small intestine, and we take this into account when we plan the treatment. But there are also other options we can use, such as having a full bladder during treatment, which I'll come on to on the next slide. So in terms of our bladder filling, as I mentioned, I've just included these figures from a study looking at bladder filling in terms of the impact on the small bowel. So within these figures, you can see here that this structure is our rectum and anus. Here in the pink, you can see that we've got the bladder, and this yellow structure here illustrates the small bowel. So you can see that if we were treating, for example, an anal cancer, we'd be treating the pelvic region here. This would be our treatment field. And when the bladder is very small, a lot of the small bowel falls down into this space. So if we were treating the rectum or the anus, for example, we'd be treating quite a significant amount of this small bowel. And if the bladder was consistently small every day and we were to treat this throughout every single treatment fraction, we'd be running the risk of this patient having definitely some acute side effects, such as diarrhea, and potentially even some late effects as well, as this dose accumulates to this organ at risk, the small bowel. But you can see in this figure here, when the bladder is full, when it's much bigger, it pushes this small bowel in yellow here up superiorly, up out of the way of the treatment field. So you can see for the same area of the pelvis that we're going to treat, by having a full bladder, we're treating much less of the small bowel, and we're reducing that risk of both acute and long-term side effects. So in terms of diarrhea that presents during radiotherapy treatment, this results from damage to the small and large bowel, as we've mentioned, which can alter their normal function. So this can include malabsorption of nutrients, altered intestinal transit, bile acid malabsorption, and bacterial overgrowth, which can all present symptoms including diarrhea. This usually begins about 2 weeks into treatment, and as we know, it can continue following treatment. So for many patients, symptoms will peak about 2 weeks after treatment finishes. And then for some patients beyond this point, symptoms may improve or resolve completely. But unfortunately, as we know, this isn't the case for everybody. And some patients will experience possibly an initial improvement in symptoms, and then symptoms recurring at any point from about 3 months after treatment up to years or even decades later, and these are known as chronic effects. Some of the management options for our acute effects that present during treatment are quite similar to some of the options for our chronic effects, which I know that Dr. Corman will discuss with you shortly. But in terms of managing side effects including diarrhea during radiotherapy, we advise our patients to stay well hydrated, drinking about 2 to 3 litres of water a day, as lots of fluids are lost with diarrhea. Some patients will also be prescribed medication to help manage these side effects. So for example, one that we definitely all know, Imodium or loperamide as it's otherwise known. So this drug slows down the bowel, it bulks up the stool and helps patients to pass less frequently. This is particularly useful if patients are struggling with getting to and from appointments due to that diarrhea. Patients may also be prescribed bowel regulators or fibre supplements such as Fibrogel or Normacol. These can absorb fluids and expand to fill the bowel, making the stool bulkier. And advice that we also always give our patients, and conversations we always tend to have with patients who have diarrhea during radiotherapy, is around fibre and around their diet. So as many of you will know, there are 2 types of fibre: insoluble fibre, which is your food such as brown bread, whole grain cereals, vegetables and fruits with the skin on. These can help with constipation, but will make you pass stools more frequently. And then there's soluble fibre, which includes foods such as oats, bananas, and apples and pears with the skin taken off. So these are the kinds of foods that we would encourage patients to include in their diet, and we would advise them to cut down on their insoluble fibre to try and help them manage that diarrhea during treatment. For patients who do have other health conditions though, for example, diabetes, we would advise this while working with a dietitian, just to ensure that that's safe for that patient. I think it's really important as well to know what works for each individual patient. So are there any certain foods that may trigger the diarrhea or make it worse? We usually tell patients to avoid spicy foods or foods that are very rich, as this can irritate the bowel further and kind of sometimes make that diarrhea more severe or more frequent. And patients may find they become intolerant to certain foods, for example lactose. So I think it's really important to know what works for each individual patient as well. In the UK, we offer these cards I've shown here, it's called the Just Can't Wait card, or a radar key as shown here. I think there's probably a similar alternative in the US, but this just helps our patients by providing them access to public toilets. So this can make the journeys in for treatment and home much easier if they can stop off and access a toilet anywhere along their route. In terms of preventing radiation-induced bowel damage, research is still ongoing on a number of different interventions, which I just wanted to mention briefly here. There is some evidence into healthy lifestyle choices through prehabilitation, certain pharmaceutical interventions, probiotics, and dietary modifications to try and reduce the acute effects during treatment. And there have been advances in the past 2 decades in terms of our radiotherapy techniques. So many centres now use image-guided radiotherapy techniques, where we take an image before we actually deliver the radiotherapy treatment each day. This allows us to see structures such as the small bowel, as we've mentioned, and sometimes have patients get off the bed to go and fill their bladder further, to then reduce the risk of treating more small bowel. And by using daily image-guided radiotherapy techniques, we can also reduce the margin that we need to treat, as our treatment is much more accurate. And we also use intensity modulated radiotherapy much more commonly now, and this allows us to use a much more conformal treatment technique. So we're reducing the dose to our healthy structures, which of course reduces the risk of acute and late side effects as well. There is some evidence of a consequential effect, and this is where patients who suffer with more severe acute side effects are more likely to develop late side effects. So if we can try and prevent or more appropriately manage the acute side effects for our patients, hopefully we'll be able to prevent or reduce the risk of late side effects as well. So we've discussed the acute side effects such as diarrhea that present during treatment, and I just very briefly wanted to introduce the late or chronic effects, which is sometimes termed as pelvic radiation disease. So some of you may have heard of this condition before and some of you may not have, and that's not surprising as this is still a very underreported and often misdiagnosed condition. So this is defined as symptoms that start or continue from 3 months after radiotherapy treatment, and these may present years or decades later and can be progressive and permanent. There are 22 symptoms listed within the condition, but I've just listed a few of them here, grouped into different categories. So urinary symptoms, nerve damage and pain, bone fractures, sexual dysfunction and infertility, bowel symptoms including diarrhea and fatigue. And as you can see, many of these symptoms are very similar to symptoms from other conditions. So as I mentioned, this is very often misdiagnosed, and this is clearly an area that we need to improve awareness on, and that's both for patients and for professionals, to try and reduce the number of misdiagnoses and to ensure that patients are managed appropriately for this condition. And I just wanted to end by reinforcing the message that this is not something that anyone should be embarrassed about. Please, if you do have symptoms that you're struggling with, please do speak to your healthcare teams about this. The most important thing is that you're able to live well, and that isn't just physically but emotionally and psychologically too. So having a good quality of life is the most important thing. So please don't feel embarrassed to speak to your healthcare team about this if you are struggling. I have just listed some references here and some links to some UK charities just in case they're of interest to anyone. Thank you very much for listening.
Okay. This is actually one of those ladies is me. This is Jeff Brown, whom I met in person when I attended a cancer conference in Houston, and he was there already ill, and we'd been corresponding by the Blog4Cure site. He was, a hell of a fighter. He was knocked very hard by this cancer and suffered financial distress, had difficulties with his job and ultimately lost his job because of his struggle with the cancer and the treatment, and trouble paying for the treatment and insurance. A friend of his and me did a GoFundMe page to help pay for his expenses. It was just a tremendous struggle, but he was a fighter to the end, and he inspires me to keep fighting.
Thank you. Okay, Jessica, you want to?
Okay.
Thank you.
Okay. Can everyone see my screen?
Yes.
Okay, super. So I'm a gastroenterologist. I'm sorry that Lauren couldn't be here. If at the end, if anyone has any questions about her slides, I'll do my best. I'm not a radiation oncologist or a radiation therapist, so I can only comment on what I know about, but I can try. But I'm going to talk about from the gastroenterology perspective, how we evaluate and treat pelvic radiation-induced diarrhea. So, acute diarrhea caused by radiation usually resolves within 2 to 4 weeks of completing therapy. But in some cases, as we all know, the diarrhea can become chronic, and sometimes it doesn't even start until 6 months or several years after completing therapy. So what do we do about that? First, you have to understand what's causing the diarrhea. And I think finding a good gastroenterologist is helpful if you find that your radiation oncologist or oncologist are not helpful. Although I will say not all gastroenterologists know what to do either, but if you find a good one, and you may have to try different ones to get the good one who can help you out. So the first thing we're usually thinking about is ruling out an infection. So we can do stool tests to make sure it's not a superimposed infection or a sort of what we might think of as what we used to call a hospital acquired infection, but is now pretty prevalent in the community. One of them is called Clostridium difficile, which is a bacteria that can take over and cause diarrhea. That's easily tested for and treated. We may want to do a breath test to rule out small intestinal bacterial overgrowth. As Lauren mentioned, when the small bowel gets in the way of the radiation field, and as radiation goes on, often people have a harder time, from what I understand, since it's not what I do, but what the radiation oncologists tell me, it's harder to hold urine for long periods of time and make your bladder really, really big, especially as the radiation treatment goes on. So inevitably there's going to be some slippage of the small bowel into the field. And then when there's damage to the small bowel from the radiation, that can sort of tack the small bowel down or kind of cause what we call stasis, where things aren't moving normally, and then you can get this small intestinal bacterial overgrowth. And that's a simple breath test and is treated with antibiotics. If there's nausea, vomiting, and pain, we usually want to make sure there's no obstruction. Again, radiation can cause strictures or narrowed segments of the small bowel. And so we want to make sure that's not happening. So we may want to do imaging. We may want to do a colonoscopy again to understand what's going on. Has the colon been injured? Especially if someone's also having bleeding, we're definitely going to want to do a colonoscopy to look. And we also often will do imaging of the small bowel. So typically in my practice, what I like to do is an MRI of the small bowel, which is called an MR enterography, because it gives a nice picture of the small bowel and the surrounding structures. And they may see a sort of narrowed, thickened segment, indicating there's been some scarring that's occurred, or a small bowel capsule endoscopy, where you swallow a pill that has a camera in it. The problem with that is that people who've had radiation sometimes, as I said, get these narrowed strictures, narrowed areas, and we don't really want the pill to get stuck. So you can do what's called a dummy capsule first, to make sure that it's called a patency capsule, where it's a sugar pill, basically. You swallow it, next day you get an x-ray to make sure it's not stuck. So that helps assure that you're unlikely to get the actual capsule to get stuck, but it allows us to see the inside of the small bowel. So that is often helpful, and you can see radiation enteritis, meaning that you can see radiation damage to the small bowel. Sometimes you get these little blood vessels that are not normal, that can bleed really easily. So often we use this if someone's having bleeding who's had radiation of unknown cause. So treatment, again, depends on what the cause is. Lauren touched on what we do in the acute setting, but then, there's sort of what do we do chronically? So often we try dietary modification, we try anti-diarrheal agents, bile acid binding resins. So if part of the small bowel slips into the treatment field and gets damaged, a lot of times you have difficulty reabsorbing the bile that your gallbladder excretes. And if that bile is not absorbed completely or reabsorbed completely at the end of the small bowel and it enters the colon, it can cause diarrhea. So we have medications that can bind up the bile. We may use antibiotics, particularly if you have small intestinal bacterial overgrowth. And then there's the question of probiotics. So in terms of dietary modifications, there's some pretty simple changes one can make. The first is a lactose-free diet. Sometimes that helps, it doesn't always. I know Lauren talked about a high fiber diet, particularly a diet that's high in soluble fiber. Sometimes actually a low fiber diet is better. And again, you have to do a lot of experimentation and it's hard to know what any one individual is going to respond to. So you have to be willing to experiment. So sometimes a low fiber diet is the answer. So like minimal amounts of fruits and vegetables. And then there's something called the low FODMAP diet, which is a diet that's low in fermentable, oligo, dye, and monosaccharides and polyols, which are short carbohydrates that often are malabsorbed by people for various reasons, which is not super well understood, but oftentimes the low FODMAP diet can really make a dramatic change where you do an elimination of all possible triggers for several weeks. If you feel better, then you start adding things back in categories one at a time to try to figure out which categories of these carbohydrates trigger your diarrhea. And it can be quite a game changer. In terms of medications, I think everybody knows Imodium or loperamide, which is the generic, which slows motility. In the United States, it's available over the counter. And it just kind of like slows everything down. The job of the colon is to reabsorb water. So if things are sped up too quickly, the colon doesn't really have time to reabsorb that water, and then the stool is really watery. So slowing down everything, which is what Imodium does, both the small bowel and the colon, just allows time for everything to firm up and for that fluid to get reabsorbed. As I mentioned, there's the bile acid binder medication. So there's cholestyramine, which is a powder. There's Colestipol, which is a pill. So those are different options and they don't work for everybody. But again, experimentation is key here. We don't really, at least in the United States, we don't have a commercially available test to check for bile acid issues. So the test is really trying the medications and seeing if you get better. There's something over the counter called IBGard, which is a delayed release peppermint oil, which relaxes the small bowel. It's sort of like a much more mild version of Imodium. And it's natural and over the counter, which you can take up to 2 capsules 3 times a day with before or after meals, because for a lot of people, eating triggers their diarrhea because things get sped up for whatever reason because of irritation and inflammation. And then there's antispasmodics. So those are medications. The generics are hyoscyamine and dicyclomine, which also relax the smooth muscle of the small bowel. So it's sort of somewhere in between, I would say, in terms of strength of relaxation, strength of controlling the diarrhea, it's somewhere between the peppermint oil and the Imodium. In terms of small intestinal bacterial overgrowth, so we do a breath test to confirm whether or not it's there. You drink a non-absorbable sugar and then breathe into a bag or into a device, depending on whether it's a home test or in an office. And they measure levels of typically hydrogen and methane to see if you have too much of the types of bacteria that generate hydrogen and methane in your gut. And there are certain cutoffs. So if the test is positive, then often treatment will be recommended. And having too much of this bacteria often is caused by, as I mentioned before, a change in motility caused by radiation, a narrowing due to the radiation. So sometimes just the radiation alone changes the motility of the bowel for reasons I don't completely understand. And then sometimes there's actual scar tissue that develops and kind of tacks the small bowel down in certain places. And the treatment are antibiotics, typically Xifaxan, which is a non-absorbed antibiotic. And if you also have methane, if you're methane positive, often they'll add neomycin. Both of those are not absorbed. Then there's probiotics, very popular out there. I mean, it's in every pharmacy. We don't know if it's beneficial. There's lots of studies that have been done, mostly looking at giving them prophylactically, meaning to be used to prevent diarrhea when people start radiation. And the studies that have been done are pretty short. Let's suffice it to say, there aren't very good studies. And there aren't very many of them, meaning they're not big enough and they're not long enough. But they don't cause harm, or I should say they're unlikely to cause harm. So again, it's worthwhile, in my opinion, experimenting. The ones that have been studied and I would say that are most commonly recommended in general are VSL number 3 and also Visbiome. Those are very similar formulations. There's Lactobacillus rhamnosus, and which is also sometimes you'll see it as L. rhamnosus GG. These are all over the counter. And then there's Saccharomyces boulardii. That's another one. And I believe that is the formulation that's in Floristore, but most of the pharmacies have a generic, or there's other formulations of Saccharomyces boulardii. So those are an option to try as well, but sometimes they make people feel more bloated and gassy, or they don't do anything and they're not inexpensive. So again, it's something that you can try, but if it's not working, move on to the next. So that's all I have for today. I'm happy to answer questions, and thank you so much for inviting me. I really, really appreciate being here.
Let's see.
Did I stop sharing? I hope.
No, you're fine. So Jessica, there were a few questions that came in ahead of time that you might start with, and then if other people have questions, they can put them in the chat box. Somebody commented that we should have those cards here in the United States, and I can't agree more.
Yeah, well, we should have them for a lot of different people. I know, I want to say the Crohn's and Colitis Foundation. I was just going to Google that, even though this has nothing to do with anal cancer so much, but they actually have an app, which is a restroom finder. And I think they have can't wait cards, but I don't know if that's, for people who have inflammatory bowel disease, but I'm sure you could probably find these cards somewhere. But unfortunately, at least in the United States, I don't think very many commercial, I don't think they care if you have those cards. People are not nice here. I don't know.
So the first question was dumping issues every 2 weeks. Somebody asked about.
I know somebody asked that, but I wasn't sure what that meant what they meant exactly by dumping.
Okay.
Do they mean, if that person is on, maybe they can write it in the chat. Did they mean that every 2 weeks they have diarrhea?
Okay. Well,
I don't.
Yeah,
I'm not sure.
Well,
I would assume that's what they mean. And if that's the case, again, I mean, you have to sort of try to find out what the cause is, whether it's dietary or whether some kind of, whether it's intestinal overgrowth, small intestinal bacterial overgrowth, which we call SIBO, or some kind of like buildup, if there's a narrowing and a blockage and there's sort of like a build of liquid stool and then it eventually passes. That's what I would think of off the top of my head. Again, you'd probably just need to see a gastroenterologist and be evaluated.
Another question was, during treatment, I have 25 tiny poops in one day. Is this considered diarrhea?
So that is a great question. I'm going to share my screen again, and I'm going to share what's called the Bristol Stool Scale, which I think Lauren talked about. And so I don't know if everyone can see this, but so there's, I'm sorry.
They look like rabbit turds.
Right. So there's type 1, type 2, type 3, 4, 5, 6, 7, and they have different consistencies. So some people have confused type 5 and type 1 when they say I have small bowel movements. the question is whether or not they're hard. So diarrhea is defined loosely, no pun intended, as you have to have type 5 through 7. So either soft blobs with clear-cut edges, passed easily, fluffy pieces with ragged edges, a mushy stool, watery with no solid, entirely liquid, and at least 3 times a day. So I would say one would qualify if you're going 25 times a day, but if it's hard, then you have something else going on. I would say during radiation, the rectum gets extreme and the anal canal are highly irritated and irritable. So anything that's anywhere near that area is just going to make you feel like you have to go. And really, there's not that much in there, but because everything's so irritable, and it also gets inflamed and narrowed. So as the rectum becomes inflamed in that acute period, you know, the rectum is where so when your rectum is full, let me give you a little physiology. When the rectum is full, it sends a signal to your brain, I have to go. Okay. Now, in someone who hasn't had radiation to that area, your rectum is normal and it stretches and it's not inflamed and it's not irritated and it hasn't been radiated. And so it can hold a lot of stool, but finally, once it gets to a certain threshold, it says to your brain, I have to go. Okay. So, but when that's irritated and narrowed and swollen and just unhappy, you get that signal constantly because the rectum thinks that it's full, but it's not really full. So that's probably what's happening with those frequent bowel movements. And in that scenario, sometimes either a little Imodium helps kind of constipate a little bit, which is a good and bad thing. Or sometimes we recommend, I like Citracel, which is methyl cellulose is the generic. It's a fiber supplement, but it's not as bloating as something like psyllium husk, which is the active ingredient in Metamucil and Conesil. So I find Citracel tends to be helpful. It also doesn't usually cause diarrhea typically. It just gives you that bulk that might help keep the stool further up instead of sliding down into the rectum where it's all irritated.
I am 5 years out of anal cancer treatment. Follow-up care for digestive problems consisted of, oh, well, you'll just have to live with it. Is this common in the US cancer centers? And is work underway to change this?
Well, I don't work in a cancer center. I'm in private practice, and I came into this world by doing high resolution anoscopy for prevention. And as I started doing that, I started to see more people who were thrivers and survivors and who need, I learned nobody taught me. So I've had to learn this all myself. Unfortunately, we're getting there. I mean, I was just invited this year to give a lecture at the American College of Gastroenterology. Actually, no, sorry, I gave it last year. In the postgraduate course about anal cancer prevention. So we have the gastroenterologists, they're not usually involved, unfortunately, in the care of patients who've had pelvic radiation. So they don't know. They really don't know. It tends to be, what happens is it becomes no person's land, like the oncologists go, I don't know, deal with it. The radiation oncologists probably know more than anybody else, actually, at least I find in my community, but I don't know that the gastroenterologists know that much. I try to insert myself into all kinds of things and give lectures. They don't always take me, but I try.
Marshall, would you like to jump in on this?
I would certainly say with regard to pelvic radiation for anal cancer treatment, given the rarity of this cancer, the oncologist that I had might have 5 cases a year. It's not something, I was very fortunate that he took the trouble to read a great deal about this. And I had a colorectal surgeon who is also trained as a gastroenterologist. Almost 12 years out now, I'm still working with this man to try to balance intake of fiber, intake of Imodium and other things to get a reasonable structure to my life. It's very awkward. I think the interaction with the chemo treatment is something that I had initially, about 2 months after I finished the treatment, a sudden, I had lost a lot of weight and I thought, okay, I'll eat some ice cream. I only learned after I did that and I had to go to the hospital that the principal ingredient in ice cream is not cream, it's milk. And I had developed a sensitivity to food protein, FPIES. And I was throwing up at both ends, if you will excuse that, and ended up having to be taken to the hospital and have all kinds of fluid injected and so forth. I learned very quickly, and I would highly recommend this to all these patients who are listening, keep a journal. What you eat, what you do. You can help your medical team. If you don't remember, and you probably don't, what did I eat 3 days ago and now I'm having diarrhea? Write it down. I'm still keeping a journal every day. What pains I have, what I've eaten, did I exercise? I do my blood pressure as well and that kind of thing. You have to, in a sense, take the initial responsibility for informing your medical team what's going on here and help them to help you.
Yeah, it's a bit of a puzzle trying to figure this out. Somebody wanted to know if you'd lost, how much weight you'd lost during your treatment.
I went from 122 pounds down to 102.
Okay.
And I went through a period when about the only thing that I could tolerate as I was going through the chemo and so forth was saltine crackers with peanut butter. Other people will have something else. I was, you have to try to take in as much as you can, but, and again, I tried to keep a record of what I was eating and whether it made me feel sick. The chemo, I had not directly related, but the chemotherapy did a number on my throat, and I still cannot eat things like jalapenos or any kind of spicy chili, which, as you can imagine, in El Paso is a real disadvantage. And how far that went down into the entire intestinal system and affected what happened. It took me about 6 months to get to a balance where it was safe to plan a trip from West Texas over to North Carolina to see family and be confident that I would not have to suddenly rush to the bathroom or not be able to on the plane and have an embarrassing accident. And with the help of the gastroenterologist, colorectal surgeon, I've reached a balance, but I do have to, I pay attention every morning, and if necessary, as he said, take an Imodium, take 2, even if you think you don't, it's not going to hurt you.
Someone is asked, do you recommend everyone have a pelvic radiation, who has had pelvic radiation, have a bowel MRI? Would a CT also show narrowing or other issues? And then what a lot of us feel, people who haven't had this symptom worry about it in the future. So I know, Jessica, you're not giving medical advice to people, but you did say what you normally do.
I only do imaging if someone's having symptoms of an obstruction, like nausea, vomiting, and pain. Or if I can't figure out the diarrhea and I'm suspecting that there is a narrowed segment. If again, I just want to say one of the other, I think, I can't remember who said it, but one of the major challenges is that, I think Marshall, you said this, that the number of patients every year is so small, and everybody's spread out across all over the place. So it's hard to develop an expertise anywhere because it's not the way the disease works. Like it only happens in New York, or it only happens in, Seattle. And so all the doctors and professionals are there. So, it's challenging as a provider when you just feel completely out of your element, you don't know. So the first thing I would say is hold your provider's feet to the fire and ask them to read about it. Say, I think I have radiation damage to my bowel. I know this is not your area of expertise, but quite frankly, there's nobody else here. You know, if you live in a place where there aren't a lot of second opinions, or there isn't a lot of expertise, and just keep going till you find someone you develop a relationship with who's willing to search it up a little bit and do some research. I mean, it's not that hard to find the information that you need. As a doctor, they just have to be willing to do it, which means you have to find someone that you fit with, that's gonna help you, that you have a good relationship with. In terms of doing imaging prophylactically, like just to check, I do not recommend that. And yes, there's also something called a CT enterography, where they're looking specifically at the small bowel, but just a plain CT doesn't usually show this unless there's an actual, like you're hospitalized with an obstruction and there's like an obvious narrowed segment. God forbid, I hope nobody ever has to go through that. That's extremely rare. But I only do imaging if there's a reason to do imaging. Like someone has to have very particular symptoms, but generally no, sometimes yes.
We tend to be worriers, those of us
course.
who have
You're
had
waiting for the other shoe to drop.
absolutely.
Yeah.
But I'm sorry that Lauren isn't here, because part of why we invited her was because in the UK they do recognize pelvic radiation disease, and we will hopefully be able to get her back to speak about this. But that is, and we need to acknowledge that the United States and other countries have a different view of this.
And it's not just anal cancer. Other people get radiation to their pelvis.
Exactly.
I mean, if you've had cervical cancer, vulvar cancer, vaginal cancer, prostate cancer, rectal cancer. I mean, there's a lot of numbers of people, and in the US, we are terrible at this. Terrible at a lot of things, but also this.
Dr. Corman, is Dr. Hips, is there anything that you recommend for irritation of the skin? Because I could only imagine after a while, it really gets to be a problem.
Diarrhea. Usually, well, number one is try to stop the cause, you know, try to get it under control. Because if you don't get it under control, protecting the skin is hard. I'm sure everybody here has their own tips and tricks. I usually recommend trying a number of things, either barrier creams like Desitin, Boudreaux's butt paste, you know, so zinc oxide. Sometimes if that's too drying, I say Boudreaux's butt paste, which is a little more moisturizing. I don't find Aquaphor and Vaseline to be the best from what patients tell me. I haven't had pelvic radiation, so I can't speak from experience. But that's usually what I say. Don't use baby wipes. If you can get like on Amazon, one of those like toilet seats with a bidet, usually that water is much easier on the bottom than, you know, scrubbing with toilet paper, or it's so tough. But really getting the diarrhea under control is so important. I mean, this is really a question for thrivers, not so much me, because I think most people know what works. What do you guys think? And women, not just guys. Sorry.
Guys is a
you all.
term.
Yes.
Jenny McCloskey mentioned that in Australia they have a product called zinc and castor oil.
That's Boudreaux's butt paste. Yeah.
Okay.
Zinc and castor oil. Yeah. Anything with the zinc oxide and oil is like a nice combo.
And I'm glad you mentioned the bidets, because I was going to try to have a picture of one, but you can buy them really inexpensively. You can hook them up to the back of your toilet, and there's fancy ones, but the unfancy ones, they're a little bit cold, but you don't have to do that whole wipe with the toilet paper. That's so irritating. So
the other thing you can do, if that's even too much, getting a new toilet seat thing or the attachment, is to get a squeeze bottle and fill it with warm water and just use the squeeze bottle. You can use the shower, you can get the bath, you know, run the water gently instead of, you know. And in terms of cleaning, you know, don't use soap. Soap is not your friend. Cetaphil Gentle Cleanser is great. As if you need to even do anything, as someone put in the chat, a watering can. Someone also mentioned, I'm sorry, calmoseptine,
Mhm.
which is also a good one. That's zinc oxide, but it has also menthol. So I always get worried that it burns, but
Mm.
if anyone has an experience that it's not, doesn't burn at all, that's good. There's so many options. I always say, go walk down the baby aisle. There's lots of good baby products because you have to treat it like a baby spot.
There was one more
Thank you.
question that
That's helpful. Thank you.
came in earlier. I go between diarrhea and constipation with no food triggers. I can find any suggestions, and this kind of reminds me of what Marshall said about keeping a journal, but any thoughts on this one? Between
I
diarrhea
would
and constipation.
Depending on where you live, I would try a fiber product that has methyl cellulose. In the US, that's Citrusel. If you're not in the US, I would look for methyl, METHYLCELLULOSE. And I find that is a good fiber product. It tends to balance out the diarrhea and the constipation. It doesn't work for everybody, but it can be helpful. That is a very frustrating problem. I would also try, if you haven't tried, the low FODMAP diet, which was developed in Australia. And it was developed by Monash University, their nutrition team there. So you can get on the internet, and if you search up Monash University, you can find their whole page. There's a lot of resources, but that's also sometimes good for people who go back and forth between diarrhea and constipation.
And Citrusel is widely available. I saw it yesterday in the Walgreens stores. I mean, it's not a difficult product to find. I was going to type this, but I'll just say it. Where I live, the population of the city and the county is almost 1 million people. I have known one person personally who had anal cancer. So my ability to sit down and talk to somebody is pretty limited. I did want to say, by the way, that talking about narrowing of the bowel area, and given the vaginal stenosis that most of us have also experienced, it's clear that the radiation is doing a lot of narrowing of body parts down there. And there's not much you can do about it, although the radiation person I had was embarrassed about sex, if you would believe, and did not tell anyone about dilators until it was almost too late to. So if you are beginning the treatment, talk to someone, start using vaginal dilators as you go through the treatment to sort of prevent this tremendous narrowing that occurs. And there are now available via social media ways to talk to other people via the Anal Cancer Foundation, for example, with their peer-to-peer program. There's the Blog for a Cure site. There are some other ways to talk to former and current patients and thrivers and just sort of get a sense of what happened to them and what did they do, which doesn't mean you're getting strictly medical advice, but just sharing experiences that you can't do in your hometown because there's nobody to talk to. It's a thought.
And Marshall, we will be doing something on sexual dysfunction as well. We have that on our list of things to work on. Somebody asked about trying to hold your bowel movements when you can. Is trying to hold your bowel movements when you can a good idea to help train yourself rather than going every time the urge comes? Any thoughts on that?
That's a tough one. I don't know that it would help, honestly.
I don't know that I could do it.
I don't know that you can, right? I mean, it depends how, I will say, I think that in experience centers now, I mean, at least in Washington, DC, me and the other high resolution anoscopy, there's maybe 1 or 2 in DC providers who are not in my group. We try to refer everybody to the same 2 people, the same oncologist and the same radiation oncologist, so they can just have their experience build so that they can be most helpful that way. And it should be also that everybody is getting intensity modulated radiation therapy, which did not used to be the case. So it depends when you were treated. If you were treated a while ago, and each center adopts intensity modulated radiotherapy at a different pace. So some radiation oncologists who are not so up to date, probably even not that long ago, were giving too much radiation, and then people develop really severe issues and anal canal narrowing, rectal narrowing, and that is very hard to, it's hard to overcome that. It's very, very challenging.
Mhm.
So I think people who are more newly diagnosed are a little better off by these newer techniques in terms of they tend to have less damage. But that's a good question. I don't know about holding it. The other thing I would mention is pelvic floor physical therapy, if
Yeah.
that's available
I
where
was
you
just going to
live.
mention that.
Yeah, because that also helps at least work on muscle strength and making sure that your pelvic floor muscles are strong, doing what you can. It's not just Kegels. I know someone just put in something about Kegels. It's more than Kegels. But pelvic floor physical therapy is really important. So finding a pelvic floor physical therapist near you, if you can, is really wonderful. That's another key component. Now you have to wait a little bit. You can't start that immediately after you just got blasted with radiation. But at some point, it's worthwhile to start, and you just ask your radiation oncologist when it's safe to begin that. But I think that's an important person to have on the team, because they can help with all the musculature, pain issues that happen later.
So we're down to our last 3 minutes. This has been a wonderful hour. This is recorded, so you can watch it again. And I believe that the chat will be there. So there's some good advice in the chat box if you watch it again. I wanted to thank everyone. Oh, we have some suggested reading here. I wanted to thank everyone for coming. And our next seminar is going to be on HRA, everything you wanted to know, but were afraid to ask. I want to thank Lauren and Jessica and Marshall and Jenny and Linda for being here in the background, and everyone who came and gave such good suggestions. And this is a huge topic taking care of us, and we're trying really hard to deal with all our concerns, and we just have to do it a little bit at a time. So thank you for being here, and please consider, if you're a patient, a thriver or survivor, joining IANS as a survivor advocate, because I think there's some wonderful things you can learn from us. Thank you.
Sorry, and thanks to the Anal Cancer Foundation for making the patients available to talk to each other. That's been a very good setup. I'm sorry it didn't exist when I was diagnosed.
Yeah, me too.